Clare Spencer. Welcome to the Menopause Research and Education Fund. We are today talking about blood tests and when you need them and when you don't. So let me give you a quick introduction. You are a GP. You are also on the BMS Medical Advisory Board. You are a menopause specialist, and you have a wonderful practice where I've just completely forgot the name of it. My Menopause Centre.
Menopause Centre.
Yes, there you go. I blame menopause. Where you look after people with menopause and all those sort of things, which is a lovely thing. So today we're talking about blood tests because these are complicated and also sometimes controversial, because there's a lot of talk about what it is we need and when we should be having it, and are we absorbing well enough, and are our bones safe, and all of those sorts of things. So what I thought might be useful was to go right back to the very, very beginning and look at what it is we're actually testing when we think we're entering menopause or perimenopause, and why we're using that particular thing rather than estrogen. So when we get to that point, we're looking at follicle stimulating hormone. Why aren't we looking at estrogen?
Yeah, okay. So follicle stimulating hormone is a hormone that is made by the anterior pituitary, which is a bit of our brain, and the follicle stimulating hormone, or FSH, basically drives your ovaries to make estrogen. So FSH is really important in an ovulatory cycle. And so when our ovaries start making less estrogen in the menopause transition, our FSH levels can increase to sort of drive your ovaries to make more estrogen. So that is essentially what we're measuring.
I think my GP described it as, when he saw my levels when I came in at 50, is, oh my God, talk about flogging a dead horse. That's I knew him well, so I wasn't insulted. But yes, it's an interesting one. But why then don't we look at estrogen?
Yeah, well, it's an interesting question. I mean, traditionally, we've always looked at FSH, and we know that estradiol levels can fluctuate, but FSH can fluctuate also. And this is the tricky issue when we're looking at any hormone blood tests. So in the menstrual cycle, if you measure FSH, if you measure estrogen, which the most active form of estrogen is estradiol, and that's what we measure traditionally. So when you look at both of those hormones, they fluctuate significantly in a normal, regular menstrual cycle. And both of those hormones really start to fluctuate even more significantly in the menopause transition. So we look at FSH, but because of that fluctuation, it's actually not super helpful to diagnose the perimenopause in the menopause transition.
Okay, sorry, I've just got a bunch of things that just popped up there on me to click away. Right, so let's say I'm in perimenopause, I come to you and I go, okay, I think I need HRT. Do I need an estrogen test then? Would you do one for a baseline? What's it going to show? Or who needs it, who doesn't?
Yeah, okay. So if we just take a step back for a moment, and I know I'm not totally answering your question first, but traditionally, because we measure FSH usually to, if we're trying to diagnose the menopause, it's the FSH that we measure. And the FSH rises in the postmenopause, and it's consistently high in the postmenopause because your ovaries aren't making estrogen, and so the FSH is persistently raised. You lose the feedback mechanism that exists when your ovaries make estrogen. They can then cause the FSH to decrease. It's quite complicated. There's a feedback mechanism. So let's just take the stages of the menopause step by step. So in the perimenopause, your FSH level will really fluctuate significantly, as will the estrogen, but the FSH particularly. So the FSH can be really high 1 minute when your ovaries aren't making very much estrogen, and then it can be low the next. So in the perimenopause, you can feel dreadful. You might be having really horrible hot flushes, feeling anxious, have low mood, and your FSH might be normal. But if you measured it the next day, it could be really high. if that FSH is really high, it's not predictive that you're in the post-menopause, because you might measure it 2 days later and it might be low again. So that's why we don't do blood tests in the perimenopause, because what you're feeling and your symptoms are far more important in diagnosing it, and how your periods have changed, etc. In the post-menopause, when your periods have stopped or your ovaries have permanently stopped making estrogen, the FSH will be permanently high and the estrogen will be permanently really low and not measurable by conventional lab means. So again, it's not that helpful. Your estrogen is low, but how you're feeling is the most important factor, and then how we're going to manage the postmenopause and your menopause symptoms. What happens is, as the estrogen levels fluctuate and then drop, your body and your brain start to adapt to that persistent low estrogen. And how long that takes is so variable. It's so variable from individual to individual. And a blood test isn't going to tell me how quickly you're going to adapt to the menopause or how severe your symptoms are.
That was what I was about to ask you, actually. So I was about to say, because we live in this massively commercialized world at the moment, where there are, home testing kits for everything, and there are social media people who are sort of pushing the idea of come and have a blood test so we can tell you where you are on your menopause journey, and we can tell you all of these sorts of things about you. But basically what you're saying is those tests really aren't going to tell you anything at all.
They give you a snapshot of what's going on that day. And so they're not predictive, and they may not be helpful, and actually might make you feel worse, because if your blood test is normal on that day but you're feeling dreadful, it's sort of almost in a way unvalidating your symptoms, if you're looking for a blood test to validate how you're feeling. So yeah, I would really think twice before entering into a blood test. And there are exceptions that I'm sure we'll come on and talk about, like, for example, younger women, but generally they are not that helpful.
No. So basically, if you're over 45, don't rely on them. Because I guess that's the other thing too with a lot of women. They'll say, well, I do feel awful. I had this test. It came back normal. The GP told me I wasn't in perimenopause, but yet my symptoms may indicate otherwise. So in that case, is it always a good idea to come to your GP, armed with a list of symptoms and severity and stuff, so you can say, well, hang on a second, today this is what my test might be showing, but 24/7 I'm feeling like crap.
Oh, Fiona, that's absolutely true. Absolutely. It's your symptoms that are the most important factor. Absolutely. And talking it through with a doctor who will listen to you and help validate what you're experiencing, being able to explain what's going on, I think is so much more important and useful and valuable to you, to then work out what you're going to do about it to help feel better.
Yeah. There's an interesting question that's just popped up over here, asking, would there be any merit in measuring hormone levels throughout a woman's life to ascertain what is normal for her? And is there any way of calculating an average? I mean, I guess we know what the averages are, don't we? From many studies, we know at this period of time levels are here, and in pregnancy they're here, and in menopause they're there. But for the next cohort of women coming through, is it worth them knowing what their normal is, so then they can see what their abnormal is? Is that a reasonable question?
Totally brilliant question to ask. And there is huge amount of inter-individual variability. So when you look at studies that have looked to work out normal values during a normal menstrual cycle, there is huge variation from one woman to the next. The issue with that is, if you look at a diagram of what happens to estrogen or estradiol and FSH, LH, progesterone during a menstrual cycle, you will see that there is huge variation during the month, and it may even vary from month to month. And the blood test may vary according to your metabolism, how quickly you're metabolizing or sort of processing the hormones. So it's a really fantastic question to ask, but I think it would be really challenging because of the massive normal variation that you would find in your normal menstrual cycle. It's not like even with thyroxine and the thyroid hormone I'm putting here, because that's where your thyroid gland is. there's even some variation there, but not as much as estrogen during a normal menstrual cycle, and then pregnancy, and then using contraception, etc. But brilliant question. Good to
Yeah,
be
it's an interesting one, isn't it? Because we're getting more into these sort of personalised medicine. So
absolutely.
it's kind of an interesting one. All right, so I've now lost my train of thought, but there you go. You mentioned there's incredible variability and what the tests do. Now, the BMS has put out a paper which really is very good in explaining the different types of estrogen and how they affect people. So basically, when we have these blood tests, what are we looking at, and what sort of real snapshot actually does it give us, given that estradiol can convert into estriol, or was it estrone? I don't remember which one now, but there seems to be this whole mixture, and then they get stuck to binding globulins and they move around. So explain all of that quagmire or quagmire, depending on how you pronounce it, of horrendous estrogen and blood mixtures.
Yeah, okay. So when we do a blood test for estrogen is a sort of umbrella term for they're female sex hormones, and there are 3 types found most commonly in a female body. So estrone is a very weak estrogen. Estradiol is the one that our ovaries make, and that's the most potent one. Then there is estriol. So estriol is formed from a combination of, often it's estrone and estradiol. And then there's a final type of natural estrogen called estetrol, and that's made by the fetal liver. So when we're pregnant with a baby in our tummy, it's the baby's liver that makes that. And they all have different roles, but estradiol is the most potent one, and that is what we're measuring. And when we measure the estradiol, we're measuring a total sum of estradiol in our blood, and that will include the free active estradiol and the less active or inactive estradiol that is bound to sex hormone binding globulin. And then there's a small fraction bound to albumin also that has some activity. So we're measuring the total, but that total doesn't indicate how much active estradiol we've got floating around in our blood. And it doesn't measure the estrone, which also has some activity. And for example, estrone is a type of estrogen that is made in our fat tissue from conversion of the sort of androgen precursors. So the precursors to testosterone can make this less active estrone in tissues such as our fat tissue. And that becomes, you can imagine, more important after the menopause. Our ovaries stop making estradiol in any significant quantity, but we do have some estrogen floating around in this less active form. And we'll talk about different types of HRT and how they interplay in a moment. So Fiona, does that make sense? Different types of estrogens. Estradiol is the most active, and that's what we're measuring, but we're measuring the total, not necessarily just the active bit.
So at any particular point in time, when you take, just like the FSH goes up and down while you're taking things, when you take a snapshot of an estradiol level, some of it may well be bound somewhere else. It may not necessarily be active where it is. It may actually have converted itself backwards and forwards into an estrone at some stage. So it's not even really giving you an accurate picture of what your estradiol level really is.
It's not giving you an active picture of estrogen activity, which is what we're really interested in, because that's what is hopefully helping our symptoms. I think the other really important thing to say is that people often don't realize, so if you're in the perimenopause and your estrogen level is seriously fluctuating all over the place, and you're taking HRT, hormone replacement therapy that contains estradiol, number one, doesn't stop the fluctuation, but number two, the blood tests that you might do in the perimenopause don't differentiate between the estradiol from the HRT and your own estradiol. So it's pretty difficult to interpret anything from that blood test unless the level is like really super low in your boots. because you would hopefully be absorbing some of it. So so that adds another layer of complexity to trying to interpret what this blood test actually means. Is it the HRT? Is it your own estrogen? What's going on? How, it gives no indication of how the estrogen is changing. And often how the estrogen is changing is really important in the generation of symptoms and how you're feeling as well.
Is it also then important in the fact that, let's just say at that particular moment, your own estrogen was incredibly low, but your HRT was actually kind of reasonable? So does that mean that perhaps at another stage, if you then think, oh my God, my symptoms aren't being addressed by this, and my level is on the bottom end of average or whatever is, therefore I must increase my dose of estrogen, that when your own level comes back up, you're going way up higher than you should?
Yes, that can happen. And also what can also happen in the perimenopause naturally is because our FSH can at times be high, driving our ovaries to make more estrogen. Sometimes you can get two hormone cycles that jumble on top of each other. So at times in the perimenopause, our estrogen level can be even higher than it was before that menopause transition, as two cycles bundle on top of each other. It doesn't last. It's a fleeting, very high, but it explains why sometimes you may suddenly get a lot of, say, breast tenderness and bloating. And that's maybe an indication that your own estrogen is really quite high. And absolutely, the HRT doesn't stop the fluctuations. And it's why sometimes actually very high doses of estrogen in the perimenopause might even make you feel a bit worse than better. It's a very tricky balance to achieve.
Yeah, absolutely. There's oh God, I saw something the other day that was basically saying, do HRT the natural way. Do what we're offering you is HRT in line with your natural cycle. And I'm thinking to myself, you don't have a natural cycle anymore. Your natural cycle has gone out the window. And as you just said, that you could have two simultaneous cycles going on at the same time. So how on earth would you be taking your HRT in line with your natural cycle, which you no longer have?
Yeah, it's virtually impossible to try and unpick it and work it out. It would be amazing if we could. It would be fantastic. But it's not going to be feasible with how unpredictably and how quickly your hormone environment, your hormone levels can change during that transition, which is why it can feel so challenging to experience, because 1 minute you can be feeling fine, the next minute you can be having hot flushes, feeling anxious, not sleeping, and then you might feel fine again. And it's very discombobulating.
Yes, it is discombobulating. I remember it well.
Mm.
The other thing then is that, okay, if you are then continuously sort of upping your dose, and you've got then all of this estrogen that's hitting the receptors all of the time, a bit like insulin, I guess. Is there any downside to that?
Yes, no, that's a really good question, because you can actually have too much estrogen. So the activity of the estrogen in your body, we've spoken about whether it's protein bound or whether it's active. The activity of the estrogen and its effectiveness is also dependent on estrogen receptors. And they're little sort of keys on the surface of your cells and on the nucleus of the cell, on the DNA, that the estrogen binds to, and that triggers a whole load of reactions and activity. And so not only then is your estrogen activity dependent on the presence of those receptors and all of the factors that they need to be active, but if you have very, very high levels of estrogen persistently, you may downregulate your own estrogen receptors. So what that means is you don't have as many receptors, or they're not as active. So the estrogen has nothing effective to cling on to. I suppose it's a bit like putting a key into a door, but the door lock isn't effective in unlocking the door. And that's called tachyphylaxis. And it's where ever increasing doses of estrogen, then actually the effect wears off. So you might be on a high dose of estrogen, it might have been helpful, but then you start to get hot flushes back, psychological symptoms or the physical symptoms. And it's because the persistently high blood level of estrogen has meant that the receptors aren't now doing their job. And that can be really challenging.
Can it be, is it reversible, or is it a bit like insulin resistance? Once the door's shut, the door's shut?
No, you can reverse it, but it can take a lot of time. And you can imagine, as you then start to reduce the estrogen dose, you can get distressing symptoms back. So you have to do it really, really slowly. It was more common when we were using more estrogen implants. So it would happen where, so an estrogen implant is a little tiny pellet that's popped underneath the skin. And we used to use them more frequently a few years ago. But if you replace the implant too quickly, or when the blood levels of estrogen were high and you were adding more and more to it, you would be more likely to get it. And it's why with an implant, actually estrogen monitoring was quite important. But it was sort of easier because you got more of a consistent level of estrogen or estradiol with an implant than you do with some of the types of HRT that we use today. So it's called tachyphylaxis, but you can get it with types of estrogen that we're prescribing now, as well as the old implants. It's less common.
Yeah, actually somebody over here is just saying that's exactly what happened to me.
Oh.
You mentioned types of estrogen there, but before we get to that, somebody did ask me a question before I forget to ask it, and that was, if I am going for a blood level test, should I put my patch gel or spray on that day or before it, or should I wait till after the test before I put it on? Does it matter?
We don't know the answer to that. And I would say, why are you going for the estrogen blood test? What are you hoping to achieve from that blood test? Because how you're feeling and symptoms is far more important as we increase the dose of estrogen conventionally. So when you put on gel, when you apply a patch, when you put on the Lenzetto spray, there will be quite significant variation in your estrogen over 24 hours. And we don't know whether you have to measure the trough level, which will be before you put the estrogen on. We don't know whether it's better to get the peak, which will be a few hours after you've applied it. We just don't know. And it is quite interesting, even with a patch, which you'd think the patch is sitting there releasing estrogen the whole time. Studies show that you do get really quite significant hour by hour variation in estradiol, even with a patch. And it reflects how quickly your body is metabolizing or processing the hormone, and it may reflect differences in absorption. It's really quite interesting.
Yeah, it is, but my God, you'd be sucked dry by the time you worked all of this out.
Yeah.
Actually, in those sorts of terms, then, I mean, something. Lenzetto likes to be put on to make a fat reservoir, patches, as you say, sort of, are there tips in some ways that people could use to sort of make sure that at least they're getting the best out of their patch or their Lenzetto or whatever, in terms of where they apply it, or their skin heat or their lifestyle or anything? Are there any tips that can actually optimize those kinds of absorption things?
Yes, yeah. So always go back to basics and read the patient information leaflet, because they've got really good practical instructions where to apply the type of estrogen. And for example, with Lenzetto and estrogel or Sandrina gels, you have to keep the skin dry for a certain amount of time, and you wouldn't want to cover it up before your skin was fully dry, for example.
I'm sure my leggings are full of Sandrina. There's probably much more leggings than there is in me.
Yes, yeah. With patches, there's some data suggesting that you might get more effective absorption from your buttock, but there's so much variation. The only thing with patches is if it's causing irritation and itching, and so your skin is inflamed underneath it, it might not absorb quite so well. But have a look at the product information, because it will tell you optimally. The information that they give you is usually related to how they've studied the method of application and that medication. And so it's worth sometimes just going back to basics and making sure that you're applying gel around the right area and the right location.
Yeah, apparently I've been doing my Sandrina wrong for 10 years, because I normally stick it Juliet Barker was telling me the other day, she said, and Miss Andrina, you do blah, blah, blah. And I said, but that's not what I've been doing for the last 10 years. So anyway, there you go. I have my little hands-free method of where I stick it on the inside of my thighs and then rub my thighs together. So I don't have to
Okay.
my hands.
Okay.
Yeah, apparently I'm supposed to move it around. So anyway, there you go. Which also then leads to the thought of other things that affect absorption rates, like, does your hydration matter? Does your does your diet, your smoking, alcohol, do those sorts of things make any difference?
So if you swallow estrogen, the timing that you swallow estrogen in relation to food and, things like exercise can also speed up how things are absorbed, so how quickly estrogen might be absorbed and then metabolized. If you're taking other medication alongside it, that if you swallow estrogen, it's absorbed into the blood supply and then it goes quickly to the liver. And so if, for example, you take other medication that speeds up how quickly your liver processes medication and chemicals, that could decrease the effectivity of the estrogen. So there are other factors that impact on swallowing estrogen in it and how much you absorb or how quickly you absorb it. And we know with skin that there are multiple factors that will affect absorption. How your skin is made up, how tight the junctions are in between skin cells, age, ethnicity, hydration, anatomical site, skin temperature, presence of inflammation or irritation. So many factors. And it's usually really difficult to control all of these factors. I know we like to try and feel in control during a time of our life where we may be feeling completely out of control. But sometimes you just have to try it and see, and try a patch. Does it help you feel better? Does it help control your symptoms or not? Try the gel. I usually say to women, look, these are the different types of having the HRT, particularly transdermally. What would you like to use? What will you not find a faff? What fits into your routine, to your exercise routine? Because it's impossible to predict usually whether one type will be better than another type of HRT.
Yeah, absolutely. I mean, interestingly, with the patches, I mean, if people ever say Fiona's dementing, she doesn't even know what day of the week it is. I've always been that way. There is no way in the world that I would ever remember which day I'd put it on and when I needed to change it. It just would never happen. So that's one reason why it would never work for me. Interesting question over here, because we're often told, have an annual review. And there's a question over here saying that, I've been told, my GP asked me to come in for to have it checked, and she said, well, what am I having this test for? Because is there any point? And the GP said, well, we just want to get a gauge on where you're at. So is there any point in having a sort of an annual blood test just to see where you are, or is it sort of a waste of time?
I would argue not, but for a number of reasons.
Except for the testosterone, maybe.
Oh, was it testosterone?
Both.
Oh, estrogen and testosterone. Okay. If you're using testosterone with your HRT, absolutely. We check the total testosterone annually to make sure basically that you're not using too much of it. So that one is a tick. That's useful. Yeah, have that done. With estradiol, I would argue that it is really unhelpful to measure it annually, because it's not going to tell us whether you're in the perimenopause or the postmenopause. It's not going, if you're taking HRT, it's a snapshot of your absorption of the HRT at that time that you're taking it. There's really poor correlation between the actual blood level and clinical symptoms, so how you're feeling. So you could measure an estradiol in one woman and she may have a level and feel brilliant, and in the next person you check it, it's the same level, but she might be having horrible hot flushes. So they're not predictive. And if you think about what I said earlier about the menstrual cycle and how the estrogen fluctuates literally from 50 picomoles per litre up to 1500 and back again during a normal menstrual cycle, we can never replicate that with our HRT. we know vaguely what the average is approximately. You can average that out for a population, and it's usually, well, it's around 350 picomoles per litre from some of Susan Davis's data, but that's going to vary hugely. So with HRT, we're really just aiming to manage your symptoms and get you feeling better. We're not aiming for a certain level of estrogen in your blood test when we're managing your menopause symptoms. So I would argue it's not that helpful, actually, but definitely get your testosterone checked, except for younger women under the age of 40, which is a different conversation because you're taking HRT. You really are wanting to replace estrogen to reduce the very significantly increased long-term health risks of a premature menopause under the age of 40. So that is a different conversation and a different discussion. And I should have maybe said that because I don't know how old the lady who asked the question is.
55.
55, yeah.
The bones. This is the other thing. We have quite a large chorus at the moment going, well, hang on a second. I've got all of my patients coming in and they're saying to me, what about my bones? Is my blood level enough to sufficiently guarantee that I'm not going to end up with osteoporosis? What do we know about that?
Yeah, so that is a brilliant point to raise because osteoporosis is a really can be devastating disease in the elder, particularly in an aging population with significant long-term effects on quality of life, etc. So estrogen, we know that estradiol helps maintain bone density and helps prevent fractures. And traditionally, we've always spoken about needing a blood level of around 200 to 300 picomoles per litre to help maintain bone density. But when you actually go back and look at the data, which I did for that British Menopause Society article, what we found was that you can have preservation of bone density at really low doses of estrogen. There isn't like a cutoff below which you have no benefit, if you see what I mean. So even using a low dose estrogen patch, even taking an ultra low dose of estrogen orally, you will prevent bone density loss and may prevent fractures. There is probably a dose related effect on fracture prevention. So the higher the dose, the more likely you are to prevent fractures. But the data is really tricky to interpret because often it's where they've measured the people who've written the papers have tried to measure estradiol level in women taking Premarin, which we used to prescribe a lot of. And that's a whole hodgepodge of different types of estrogen. So, yeah, I think we have to accept that at the moment, we don't know what the threshold is. But the reassuring fact is even low doses of estrogen will prevent loss of bone density and help prevent fractures. And then obviously it's really important around that. We're taking our vitamin D, we're exercising, we're making sure that we've got enough calcium in our diet. It's not just about the estrogen, although that is a really important part of this.
Yeah. God, I did one of those tests the other day, actually. And, I thought I ate a lot of calcium, but I didn't make the threshold. And I was quite a long way off. Either that or my maths is incredibly difficult because I did look at my maths does really, it's bad. But I looked at it, I thought, I was thinking, then in the end, they're actually quite difficult tests to do because some of them measure milligrams of cheese and others measure grams of cheese. And so in the end, I'm having to think, okay, if I bought a 250 gram block of cheese and ate it over the week, how many milligrams a day did I eat? And it was thinking, I can't do that. It was hard.
Yeah. Was that on one of the calcium calculators?
Yes,
that you can access? Yeah.
Yeah, honestly, I looked at this and I thought it was almost. I mean, I'm thick. It's true. I will admit it. When it comes to mathematics, I'm just forget it. But literally, I looked at that and thought, if I'm struggling with this, an awful lot of other people will because they're going to read it wrong and they're going to think that they're either going to get a false sense of security or they're going to be massively underestimating it. One of the two, because it was almost like it was the mathematical equivalent of mixing your metaphors.
Yes, it takes a lot of working out, doesn't it? That there are varying levels of complicated calcium calculators. There's the Royal Osteoporosis Society, they have one, the International Osteoporosis Foundation, and then there's an Edinburgh one as well. So there are different ones.
Too.
You did, yes.
I did both of them. I found them both as equally awful. Yes. The other thing I guess about the bones too is that, I mean, I did a really good interview with Mike McClung out of America a couple of months back, who worked on the FRAX score with who many years ago, and did an interview for the IMS saying that, listen, we really were going to get to these people with who are entering menopause, entering that late stage of perimenopause with low bone density already, because they're the ones who we really have to target. So I guess in terms of if we were in an ideal place, we would be identifying those people and going, well, hang on a second, you're at -1 already. You're the one who really needs to make sure you've got to have a reasonable amount of estrogen or something, or whatever your choice is, if you can't take estrogen, to make sure your bones are all right, as opposed then to just having a blanket approach where we think everybody must have a certain amount of estrogen to preserve their bloods, because most people, my DEXA score was +2, so I'm probably not going to be osteoporotic until I'm 95, but he was saying if you're entering at -1, then by the time you're 65, you may well be. So it's sort of, again, very individual.
Oh, that's such a brilliant point. I completely agree, because it's not just one single factor, is it? It's what your other risk factors for loss of bone density and osteoporosis are. So that includes family history of osteoporosis, whether you have a parent who had a fracture, like hip fracture, how much alcohol you're drinking, whether you're smoking, what your body mass index is, whether you have any other health conditions that can significantly increase your risk of osteoporosis, like you've taken long-term steroids, for example, rheumatoid arthritis. If you Google FRAX score, and Fiona, I'd be really interested to watch your previous video as well, that there's really good information on there, and as well as those other websites that we've mentioned.
Yeah. Basically saying we're leaving it too late by relying on FRAX. We're getting people when they're already fractured. Let's go back to the beginning and find these people who are at risk earlier on.
Yes.
All right, where are we now? I've sort of lost my train of thought because we went off again, didn't we? Bones, blood tests.
Early menopause, the earlier the age that you lose estrogen. So if you've had a menopause under the age of 40 or probably 45, again, you might be at increased risk. And so that you would be able to measure your bone density with a DEXA scan if you have a chat with your GP, if you're worried about whether you are at risk.
Yeah. I've regained my train of thought, and it was, at the moment, we have a sort of, are we somehow perhaps thinking that, if I'm on HRT, all of those symptoms that I had before, my anxiety, my bloating, my itchy skin, my dry eyes, absolutely everything, HRT is really going to solve them all, and I should never have issues with these again. Is this partly, do you think, something that's sort of driving this sort of leveled argument, and I must be tested and I must have more? But is there also a thought that perhaps, I mean, even Sue Davis's, which I know you haven't seen, but I'll quickly run you through it. Sue Davis is a professor in Australia at Monash University who does a lot of research. I think she's had more than 450 or so papers studied on menopause and especially testosterone and estrogen type things. And she's done a study that looked at midlife women, and I think there are around about 5,000 in there in the end, who answered a questionnaire. And when they were doing this, they picked them not as an opt-in. They actually, they went through like a randomized process of through a what do you call those people who do like the exit poll people who ring up 1,000 people and randomly and get their opinion on who's going to win the election? Those types of people, the ones who randomly pick people. Yeah, the people who run those polls, those people. So it was sort of, you weren't just getting people who were opting in because they thought, I need to answer this because I've got a problem. So it looked at that whole sort of midlife section, and what they found was in premenopause, a lot of the symptoms that we attribute to perimenopause, the anxiety, low moods, and various other sorts of things were quite present then.
Mm.
So basically, the logic of it was, but she also found that vasomotor symptoms started much earlier than we thought. So basically, they found a lot of actually interesting things, that around about 40% of Australian women are not being treated for their menopause symptoms, for their vasomotor symptoms. But apart from that, they were saying that we can't necessarily say then that anxiety and a couple of those other sorts of issues, weight gain and things, are necessarily symptoms of menopause, or things that we could diagnose on. So we can't put them into I can diagnose perimenopause by these symptoms. But is there then a thought that because we have these things, that they should be all cured by HRT, and that's sort of driving that point of I must need more and I have to have my levels tested? That was a roundabout way of saying, can all of your symptoms be cured by HRT?
Yeah, no, and thank you. That's a great summary, and I will go and read that paper. It is interesting, and I think what it shows is how challenging also it can be to diagnose the perimenopause. And I will answer your question in a second, but we know before the perimenopause starts, you can get worsening of premenstrual symptoms as your estrogen drops and your progesterone levels drop just before you have a period. So no, absolutely. And it's really challenging. And so HRT, realistically, for some women, it makes them feel brilliant, and it really does turn around symptoms, and it's great. I would say realistically that is not all women, and that's probably a small percentage. And so the symptoms that so I think there are a few different points here. So often we ascribe symptoms to the menopause that might not be related to the menopause. And often because HRT can never replicate those physiological levels of estrogen, I'm doing that because of the up and down of estrogen during the menstrual cycle. You know, HRT can fill in some of the deep gaps, but it's never going to, we know that it can't prevent or stop all of the symptoms of the menopause. For most women, it will help manage hot flushes and night sweats, but not for every single woman. And it may not help every single hot flush and night sweat that you might have. Brain fog is a really distressing symptom. It causes untold anxiety, stress, women worrying about their performance. But it may be that pure HRT by itself, if you start it in the postmenopause, might not help all of those brain fog symptoms. Now, brain fog is a tricky one because poor sleep worsens brain fog, stress, anxiety, hot flushes, night sweats by themselves. And actually, if you can help some of those symptoms with the HRT, it might help brain fog. But my point being, the HRT by itself might not help everything. Bloating, skin changes, skin elasticity. Sadly, a lot of these changes occur with increasing years. I hate to say it. Also, that HRT, yes, nails, it might not. Hair, it might help. It might not help. Hair loss. It's incredibly challenging. And as I said earlier, particularly in the perimenopause, often symptoms are set up because of more estrogen fluctuation that the HRT doesn't stop. So we know that if you have more estrogen fluctuation, you may have more psychological symptoms, for example. And the HRT may not be the best way of managing those. Actually, the combined pill, if you can take it, might be a good way of managing some of that fluctuation. So that's a very long way of saying HRT may not help manage every symptom of the menopause as much as we would love it to. Menopause care is so much more about practicing holistically and looking at lifestyle, managing stress, actively managing relaxation, actively managing sleep, as well as HRT and other medications if you can't take HRT. And so measuring your estrogen level may not be super helpful. We want to, as doctors, we want to make you feel better. As women, you want to feel better. So, am I absorbing this HRT? I just don't know. I've still got these symptoms. It's so tempting to reach for a blood test, but it's just getting over the message that that single snapshot blood test may not give you all the information that you want. It might not be helpful. It may be better to sit down and have a good discussion about the HRT that you're taking, what's going on in your life, you know, what are your stressors, what are you trying to achieve? Do you know what I mean? It's far more complicated than a blood test equaling the answer.
Yeah. Now, this brings me to the next question over here, which actually you'd mentioned as well, which was, hang on, did we answer her? Saying getting to it, which I've just totally butchered because I'm typing with my left finger, which was stopping HRT. Now, there are many of those cartoons where you see the woman racing towards a grave with a HRT in one hand and a gin and tonic in the other. So are there can you stay on it forever? How long do you have to? Is there a specific end period? Can you stay on it? Are there any risks of being on it? And how do you know when you should be coming off it? Which is a question for me too, because you know I'm 61 now. How much longer should I stay on it?
Yeah, and I think it has to be a really individual discussion with yourself and with your doctor or other healthcare professional. So while you're on HRT, it's not pausing your body and your brain adapting to that new state of low estrogen. So when you stop HRT, you will feel how you were going to feel when you stop it. So that's the first thing to sort of think about. So many women say, I'm terrified of stopping my HRT because I'm so frightened of feeling how I felt, for example, in the perimenopause. So you will feel how you were destined to feel at that age anyway, if you know what I mean.
Oh my God, it'd be a bloodbath. I think I will be taking it until I go into that grave. Yeah. I'm not known for my tolerance.
Okay. So the next thing to consider is the fact that we can't get away from the fact that there are small risks to taking HRT. And you need to make sure that the HRT type is the safest for you. So if you're at risk of blood clots or heart disease or stroke, it's safer to have the estrogen through the skin, and obviously with the progestogen with it if you haven't had a hysterectomy. So make sure that you're on the safest type of HRT for you at the age that you're at. So for example, if you're having oral estrogen and you're encroaching onto and into your 60s and beyond, it is safer to switch to estrogen through the skin, as your risk of blood clots naturally increases with years also. There is that small risk of breast cancer that is related to how long you take HRT for. You know, it's consistent among the studies. We can't get away from that. And so again, well, what's your own risk of breast cancer? Are you at higher risk or not? And you know, some people say, oh, I now feel uncomfortable about taking this HRT, so I'm going to stop it. Other people carry on taking it because of they feel the quality of life it gives them. And then obviously, if you're at risk of osteoporosis, you may be more inclined to stay on HRT and accept that small risk of breast cancer. And we know for women up to their sort of early 60s, for most women, if we think population, the benefits usually outweigh the small risks, but we just don't know what that ratio looks like then for women as they increase in years. And just because we don't know doesn't mean it's more risky or less risky. It just means we need more studies. We just don't know. So I just think it's such an individual choice. Some women will take HRT till they retire and then try decreasing the dose, see how they feel, and then stop it. Other women will retire, then start HRT. I've spoken to women. So it's really tricky. And if you stop HRT,
you would come down slowly. But then if you found at the end of 3 months or something, or 4 months, that you were about to take a chainsaw to your family, not that I'm saying I would,
no,
then you could
start that. Yeah, totally. And you can stop it, see how you feel, and restart it. That's totally fine, obviously with your doctor. And if you stop it, it's just really important you pay attention to what my heart disease risk factors, am I managing them? What are my osteoporosis risk factors? Am I managing them?
Yeah. And in terms of the breast cancer risk, that's mostly associated, they say, with the progestins. Are there some then that, you know, would you be better off if you are thinking of staying on it long term, perhaps having a coil rather, or picking your progestin carefully?
Yeah, that's a really good question. So estrogen only HRT, if you've had a hysterectomy, has a lower risk of breast cancer than combined HRT, estrogen plus progestogen. But there is still an increased risk of breast cancer with duration for women on estrogen only HRT. So we can't say that is no risk. There is some data suggesting that if you have body identical progesterone, which is found in, so it's micronized progesterone, so Utrogestin, Gepatix, there was a marginally lower risk of breast cancer associated with HRT containing micronized progesterone than other synthetic progestogens like norethistron. But in actual absolute numerical terms, the difference is going to be marginal. And the Mirena coil still does have a risk of breast cancer associated with it, and nobody's done a comparison study comparing risk of breast cancer from HRT with a Mirena compared with HRT with a swallowed or transdermal progestogen. So we just don't know the answer to that.
Right. We're often quite told that that stays more locally, so your risk would be lower. But you're saying that's not necessarily the case.
Yeah, I don't think we can say that there is. It's a low risk of breast cancer, but it's not zero risk. And yeah, we just don't know how that translates into increasing age. It is the most effective way of protecting the womb lining, so it definitely has other advantages.
Yeah. Kate over here is saying, I have borderline osteoporosis recently confirmed. So advice is to remain on estrogen and have further test for thyroid absorption and minerals. That actually brings me to one other thing. I will eventually let you go. I'll stop torturing you in a moment. Is the idea of other lifestyle things, vitamins and mineral supplements, and those kinds of things, and osteoporosis. Do we really need them? We have a lot of things that are on the market at the moment as well, saying, my God, if you don't take my beautiful supplement, you will turn into, literally, as I said, an ab-fab many years ago, gristle hanging onto powder. I love that phrase. Is there, do we need extra things, or really is our lifestyle necessarily going to be enough?
Yeah, so look, vitamin D is really important for all of us living in the UK, men and women, during the winter months, because there isn't enough sunlight to make active vitamin D. So from, say, September to April, everybody should take at least 400 international units. But it's more important for women going through that menopause transition that you have enough vitamin D, because that helps us maintain, it helps the building blocks of bone density. And we should make sure that we're getting enough calcium in our diet by using one of those calcium calculators if we can. And you only really need to take calcium if you know that you have a condition where you're not absorbing it adequately, or your diet is very deficient in it. So that is the biggie. So vitamin D, many women have really horrendous periods in the menopause transition, the perimenopause, so that iron can be depleted. So taking iron can be important. Low iron doesn't help hair loss, and you can also get restless legs. So not everybody needs iron, but it's worth considering if you're having really heavy periods. But they are the only ones that I personally would recommend, with a good evidence base behind. There are bits and bobs of evidence for other things, but vitamin D is the main one.
Yeah. Brilliant. All right. I think we've covered it, really, haven't we? I think we have. I feel like I've been through a small exam. Where are we at then? So basically the take home message is there's really not a lot of point in doing estrogen tests, really.
Yeah, so if you go through the menopause under the age of 40, and you really need to make sure that you are having adequate amounts of estrogen, although there's no evidence to tell us what the best estrogen checking regime is, that's when it can be useful. FSH blood test I didn't mention earlier, but if you're not bleeding because you're using progesterone only contraception and you want to know when to stop it and you're not taking estrogen, checking an FSH can be useful in helping you work out when to stop using contraception. But other than that, if you're still having symptoms on your HRT, then having a chat with your doctor is far more worthwhile. Change your HRT, look at lifestyle factors before just reaching for an estrogen blood test, because it might not be super helpful. So that they would be my take homes. And if you are using very, very high doses of estrogen, then it, just seeing where that level is, it might be important if we're worried about tachyphylaxis and almost having a bit too much estrogen, acknowledging we don't know really how much too much estrogen in your blood is. It's an area where we need so much more research, but I think they're my take homes. I agree with you. There aren't very many circumstances when an estrogen blood test is hugely helpful, unfortunately.
Yeah. One other area where we need huge amounts of research, and Petra has just touched on it over here with a question saying, what is the percentage risk generally for breast cancer of staying on HRT long term? I understand it will vary, but generally, considering an article the other day said there was a 13% risk if you drink alcohol. I really wish people would stop using percentages when they put these up. It drives me absolutely batty. There was something this morning that popped up. Sorry, Petra. I will allow Claire to answer in a second. This morning, saying that an influencer saying that HRT increases longevity, and so I thought, let me have a little look into this. So I sort of dived into an article this morning, as you do, into a journal article, which basically, looked at people over the ages and whether or not they were taking HRT and the difference between how much longer they lived if they were or they weren't. And literally, when you looked at the absolute figures, if you looked at it as a percentage, you think, oh, that's pretty big. You've got like a 15% increase in your longevity. But it was literally, 4 people out of 10,000. It was compared to 15 people, or not 15, but I'm making the figures up. But the difference was tiny when you looked at the absolute figures. Anyway, so apart from the 13%, literally that 13% could have been, 3 people more in out of however many. I don't do maths, as we've already established. But anyway, do we actually have data on long-term risk? Because we haven't really had people studied on long-term HRT for forever. So what do we know?
Yeah, no. I think it's a really good point to raise, because 13% of what? It's really difficult to work out what that means, isn't it? There's some really good data that has been put together by a breast surgeon called Joe Marsden on the British Menopause Society website. That there's a really good diagram on there that summarizes the findings of the Women's Health Initiative study, showing absolute numerical numbers of excess breast cancer diagnoses from women using HRT. And there's information there showing that with time, that number doubles. So, for example, there may be 4. These numbers are not exact, but on the baseline per 1,000 women over 5 years in their 50s, there may be 4 additional cases of breast cancer diagnosis from the Women's Health Initiative study. And with increasing time, that may increase to 8 or 9 or 10 after 8 years. But there is very little data. But that would be a more than doubling in risk. But actually, as you just said, in absolute numerical terms, it is a small number, but that is really not to diminish the impact if you are one of those small numbers of women. So there is data, and the British Menopause Society has information on it. I won't talk through the exact numbers now because it depends on the study and the way that the data has been put together. The other place to look is the updated NICE guidance. Has some really useful decision-making tools that summarize statistics, again, in absolute numerical terms. So number of increased cases of breast cancer, number of fractures prevented. So I'd have a look on the NICE website as well. But it's an excellent point to make.
Yeah, and Petra, that wasn't having a go at you about using the percentages. But that's exactly why we ended up with the whole hysteria from the Women's Health Initiative when they came out and said 26% increase in breast cancer. And it was sort of like, well, hang on a second, these figures are tiny.
What does that mean?
Yeah, exactly. So that wasn't having a go at you, Petra. It's having a go at the headlines, of which, being a journalist, I have been responsible for. But when I left mainstream journalism and went into medical publishing, it was just when the WHI study came out, and the stark difference between the way the medical press and the mainstream press handled it was incredible. And I write about it in my book, actually, in Menno Wars, which is out in September, shameless plug, about how, when you're sitting in a newsroom, you don't have that statistician at the end of your desk sort of going, oh, well, hang on a second, that's not exactly what this means. You just look at that figure and you go, well, 26%, woohoo, headline. And yeah, the percentages can be really misleading. Anyway, that was my thought. So on that note, I will stop torturing you. Thank you very much. Where do people find you if they wish to find you?
Sorry, say that again, Fiona. Sorry.
Where do they find you should they wish to find you?
So www.mymenopausecentre.com.
And you have a wonderful newsletter, actually, which is definitely worth signing up for. Yes, exactly. Brilliant. Well, look, thank you so much again. And we will speak soon. And I'm glad you didn't take that personally, Petra. I will end this now and I will talk to all of you later. Take care.
Thank you for inviting me.
Pleasure.